you very much again, and again for people who are not attending the last session. I would like to apologize to present in a shirt and jeans without jacket because my suitcase did not arrive with me last night. So I'm sorry again. So now I will speak about fluid administration and the right ventricle. Just to say first that there are major causes of acute right ventricular dysfunction in critical patients. First, sepsis-induced myocardial dysfunction, acute pulmonary embolism, RV dysfunction due to ARDS. And for example, during ARDS, we can have hypoxic vasoconstriction resulting in a high pulmonary vascular resistance, mediators-related vasoconstriction, perivascular edema, microthromby in pulmonary vessels, microvascular remodeling. All these factors can lead to increase in pulmonary vascular resistance, increase in the right ventricular afterload, and can create some RV dysfunction. But there is another factor, which is mechanical ventilation, and we can have deleterious effects of mechanical ventilation on the right ventricle. I would say that the first one is a RV dysfunction due to acute decrease in the contractility of the right ventricle. And the other ones are acute RV dysfunctions due to an acute increase in the pulmonary vascular resistance. Different mechanisms. It is a way to classify RV dysfunction. But there is another way to classify, and this is my way to classify, my own way, personal way to classify. I would say that the first three causes are structural causes of RV dysfunction, while the last one, the deleterious effect of mechanical ventilation, is the functional cause of RV dysfunction. And I will explain you why I differentiate structural and functional causes of RV dysfunction. Because when you give fluids in patients with structural cause of RV dysfunction, what happens? What happens? To understand what happens, we have to look at the Frank-Starling relationship again for the right ventricle. Stroke volume, ventricular pressure. If you are in the case of probe responsiveness, no problem, you have an increased stroke volume. But if the RV is dilated because of the structural cause of RV dysfunction, you have no increase in stroke volume, no increase in cardiac output. So, when the RV is dilated, fluid infusion results in no increase in RV stroke volume. But we also have to think about the diastolic function of the right ventricle, which is like this. If you give fluids while the RV is not dilated, no problem, you have a small increase in the filling pressure. But if you give fluids while the RV is already dilated, you have a huge increase in the right ventricular and diastolic pressure, with a high risk of increase in pressure upstream, with liver failure, kidney failure, etc. So we have to be very careful in this situation. So, if the RV is dilated, fluid infusion should result in a large increase in RV-ADP. So, no increase in stroke volume and large increase in RV-ADP. So the double penalty is accurate. But in addition, if you give fluids to an already dilated RV, right ventricle, you should have a movement of the septum to the left, which can impede the left ventricular filling. This is a biventricular interdependence phenomenon. So, because of this, you have a decrease in the stroke volume of the left ventricle. This is a triple penalty. So, fluid infusion, in case of RV dysfunction due to structural causes, sepsis-induced myocardial depression, acute pulmonary embolism, or ARDS, not only does not increase, but can even decrease cardiac output. So it is very dangerous to give fluids to a patient with RV dysfunction due to a structural cause of RV dysfunction. Totally different is this other cause of RV dysfunction, which is a functional cause of RV dysfunction and what I call the deleterious effects of mechanical ventilation. What I mean? I mean that in the lungs we have two categories of vessels. We have the intra-alveolar vessels and the extra-alveolar vessels. So when you increase lung volume by giving PEEP or by giving tidal volume, you, by definition, you increase pulmonary blood lung volume, you increase lung volume, and you dilate the extra-alveolar vessels, extra-alveolar stretched, dilated, and you can compress the intra-alveolar vessels, which are directly submitted to the outside pressure, which is the alveolar pressure. So, you increase lung volume, you should decrease the resistance of the extra-alveolar vessels. And if I represent this on this graph, this is a classical graph, classical representation of the relationship between PVR, pulmonary vascular resistance, and lung volume. RV is residual volume, FRC is functional FRC, I missed the word, and TLC for total lung capacity. You have this decrease in the resistance of the extracellular vessels, which is finally maximum for the FRC, and after you have no further decrease when you dilate, because you cannot dilate more than some point. Okay, and now at the same time, when you increase lung volume, you increase the alveolar pressure also in mechanically ventilated patients. And this should increase the intrathoracic pressure, the pressure inside the thorax. But the pressure inside the thorax increases less than the alveolar pressure. There is some decrease in transmission. So the transpulmonary pressure, which is the difference between alveolar pressure and intrathoracic pressure, increases during increasing lung volume. And this could increase the resistance of the intra-alveolar vessels. In fact, we have three zones in the lungs, what we call the rest zones, 3, 1, and 2. For the 3, the alveolar pressure is lower than the pulmonary artery pressure and the pulmonary venous pressure, because we are at the bottom of the lungs, and these pressures are higher than here. So there is a lot of chance, of course, to have this higher than this and this higher than this. And there is no resistance or minimal resistance in this part of the lungs. Totally the difference is in the top of the lungs, where the alveolar pressure can be higher than the pulmonary artery pressure and the pulmonary venous pressure because of the hydrostatic gradient, negative gradient. Now the arterial pressure is low, the pulmonary venous pressure is low, and you can have this compression, squeezing of the capillaries in the alveoli. Zone 1 conditions, the resistance is extreme. And you have the intermediate zone, zone 2, where the alveolar pressure is higher than the venous pressure. And in this zone, you have a high resistance and low flow, low blood flow. And the PVR, pulmonovascular resistance, increases from the bottom to the top of the line. This is another representation of zone 1, zone 2, zone 3. Zone 3 is better, of course, because you have maximal blood flow and you have low resistance. So the higher the zone 3, the higher the extent of zone 3, the better for the right ventricle. And if I represent this on this graph, we have an increase in the resistance and a huge increase after the FRC. So the resulting effect is the U-shaped curve, relationship between pulmonary vascular resistance and lung volume. And the minimal PVR is for the FRC. Now, FRC, okay, you increase tidal volume from the end expiratory lung volume. If you use a low tidal volume, you have a small increase in the resistance. So it's good. It's not so dangerous. Of course, if you increase more tidal volume, you have a higher increase in the resistance in the pulmonary vascular vessels. It's not so good for the right ventricle. What about PEEP application? Now, we have two categories, two different situations. One is if PEEP recruits lung units and increases the end expiratory lung volume, which is small, towards the FRC. So now we start from this point, on the left part, and you should decrease the pulmonary vascular resistance. If you have a recruitive PEEP, only no overdistension, you should decrease PVR and not increase PVR. And now, if you give a tidal volume, okay, you have a small increase in the PVR, okay? But if you have an overdistending PEEP, if PEEP increases the end expiratory lung volume above FRC with overdistension, you should have an increase in PVR, and more if you apply tidal volume. And if you apply a high tidal volume, higher tidal volume, you have a higher increase, an exponential increase in the resistance. Look at this, higher tidal volume. So we have to be very careful. This is why. This is not why, but it is one of the reasons why we like to decrease tidal volume, not only to avoid the deleterious effects on the lungs, but also on the right ventricle. And this is well demonstrated or illustrated by the study by François Jardin and Antoine Pierre-Baron in the past. They look at the plateau pressure, which combines PEEP and tidal volume, of course, it's a combination, and mortality. Look, the higher the plateau pressure, the higher the mortality, but also the higher the rate of acute cor pulmonale, which is the extreme form of RV dysfunction. When you have a high tidal volume, you have a high risk of RV failure because of the combination of PEEP and tidal volume. Now, if you use protective ventilation, as we said, protective ventilation, and if we use echocardiography to define acute cor pulmonale, defined, as you see, as a RV-EDA over LV-EDA ratio about 0.6 plus cetodyskinesia in this multi-center study, including more than 700 patients, the prevalence of acute cor pulmonale is 22%. Okay, even using lung protective ventilation. And the driving pressure is one of the factors associated with the occurrence of acute cor pulmonale. In another study, we did years ago, we defined acute pulmonary differently. And we use a Swabian's catheter, and we use a mean PAP above 25, right atrial pressure above POP, and stroke index less than 30 ml per meter square, and we found an incidence of 10%. So it is between 10% and 22%, depending on how you define acute pulmonary. So we know that reduction of transverse pressure using ventilatory strategies aimed at limiting plateau pressure is associated with a high reduction of incidence and severity of acute pulmonary. Okay, and this is why the surviving sepsis campaign guidelines and others recommend to limit tidal volume and to limit plateau pressure below 30 centers of water. I have a question for you now, because I spoke a lot. Now it is for you. What do you think about the effects of PEEP in ARDS patients? It increases cardiac output, decreases cardiac output, exerts no effect, or it depends on volumic status. What is your opinion? Who votes for number 1? Increases cardiac output. Nobody? Number 2? Nobody? No, you are shy. You are shy. Who votes for number 3? Exert no effect. Nobody? It depends on volume status. Some. Yes, it depends on volume status. Look at this representation of the waste zones. Here you have extended zone 3, more zone 3 than zone 2. And now, just imagine, you decrease the pulmonary venous pressure by hypovolemia. You decrease the pulmonary venous pressure, so now the alveolar pressure can be higher than the pulmonary venous pressure. And you have more zone 2 conditions. And now you have an increase in the pulmonary vascular resistance. So hypovolemia should increase the resistance of the pulmonary vessels. And this is not good for the right ventricle. So hypovolemia amplifies the deleterious effects of mechanical ventilation plus PEEP on RV function. And this is like this. We have more zone 2, so now we have a higher resistance of the pulmonary vessels. And we illustrated this in a study published some years ago with Émilie Fougère and Xavier Monet in our unit. We studied patients with ARDS, with low tidal volume at the beginning and low PEEP, 5 centimeters of water at the beginning. And after we increased PEEP until reaching a plateau of 30 centimeters of water without changing tidal volume. Okay? 30 centimeters of water was the maximum plateau pressure. And the average PEEP level was 13 centimeters of water in these patients. And we performed a passive leg raising, not to predict full responsiveness, I told you before, but just to simulate a volume challenge, like a volume challenge. So we increase the central blood volume using PLR. And we measure the effects with Swabian's catheters and with echocardiography. Okay? What we found? We found with high PEEP, I would say 13 centimeters of water, we found a decrease in cardiac index. It is not surprising. It's not new. Increase in cardiac index. But we observe an increase in the pulmonary vascular resistance, increase with pulmonary vascular resistance. And also, we observe an increase in the right ventricle, left ventricle and superior ratio, which is a marker of RV dysfunction. Increasing, meaning more RV dysfunction. So, with PEEP in these patients, we observe an increase in the right ventricle afterward with PEEP. After this, we perform a passive leg raising, simulating volume change. And what we found? An increase in cardiac index and a decrease in the pulmonary vascular resistance, a decrease in the resistance, and a decrease in the RV dysfunction. And now, the ratio returned to baseline. So, by giving volume, we decrease RV dysfunction. We decrease right ventricular afterload. And it was a little surprising for people to hear this. For us not, because it was our hypothesis. So what we did, in fact, by giving volume, PLR is like volume, we extended the zone 2 conditions. Because we increased pulmonary venous pressure. This pressure was increased. And this became higher than the alveolar pressure. And the resistance decreased. We moved from this curve to this curve. So my conclusion, in critical patients, RV dilation may occur due to structural causes, pulmonary embolism, ARDS-related pulmonary hypertension, septic myocardial dysfunction. In this case, fluid infusion cannot increase cardiac output and can even decrease cardiac output. In mechanically ventilated patients, RV dilation may also occur due to mechanical ventilation itself, high pulmonary transplant pressure, increasing PVR due to extension of zone 2 conditions. And by increasing pulmonary venous pressure, fluid infusion can restore zone 3 conditions and thus can decrease PVR and RV size and can increase cardiac output. In case of any doubt, a PLR test can be helpful, essentially in ARDS, where structural causes and functional causes may both exist. So, if you have no certainty, you can perform PLR and look at the change in cardiac output. In any case, the benefit-risk ratio of fluid infusion must be carefully assessed, and especially in ARDS, where the capillary permeability is altered. So fluid can be dangerous also for the lungs. So we have to think before giving fluid or before giving any treatment. Think before, it is better than think after. Muchas gracias.